Welcome to The Explainer. Today we are going to break down everything you as a pharmacist need to know about managing venous thromboembolism. You know it as VTE.
Let's kick things off with a pretty sobering number, 5%. Up to 5% of the entire population will have a VTE in their lifetime. So yeah, this is a really common, really serious condition that you're absolutely going to see at the pharmacy counter, and probably pretty often.
And you know, the stakes? They are incredibly high. VTE is responsible for up to 10% of all deaths in hospitalized patients. That single fact just highlights how crucial our role is in managing and preventing these clots.
All right, so let's jump right in. Here's what we're covering today. We'll start with the challenge itself, look at our anticoagulant toolkit, walk through treatment from start to finish, nail down patient counseling, and finally, touch on some special populations. It's all about giving you what you need for that patient standing in front of you.
First up, the VTE challenge. And believe me, it is way more than just a clot. Let's frame the problem we're actually trying to solve here.
So VTE, it's the umbrella term for deep vein thrombosis and pulmonary embolism. But the thing is, it's not just about surviving the initial clot. The long-term fallout can be brutal. We're talking about things like post-thrombotic syndrome, which can hit up to 40% of DVT patients, causing chronic pain, swelling, things that really tank their quality of life. And that's exactly why getting the treatment right is so incredibly important.
Okay, so now we get the challenge. Let's talk about the tools we have to fight it. This is your anticoagulant toolkit, and it's all about choosing the right agent for the right patient.
Inside that toolkit, you've basically got 4 major classes of drugs to work with. The DUACs, good old warfarin, the low molecular weight heparins, and unfractionated heparin. Each one has its own quirks and personality, so picking the right one is where the art of pharmacy really comes in.
And this is where things get really interesting. Look at the contrast here. On one hand, you've got the DOACs. They're fast-acting, you don't need constant monitoring, and there are way fewer food interactions to worry about. They've been a total game changer. But then you have warfarin. Slower onset, you absolutely need that INR monitoring, and you have to counsel on a ton of drug and food interactions. It's a completely different conversation with the patient.
All right, so we have the tools. How do we actually use them? Let's walk through the game plan for treatment from the very first dose to the very last.
This really lays out the different ways to get started. Look at apixaban and rivaroxaban. It's so straightforward. You start with a higher dose, then drop down. No needles, no bridging. Simple. But then you have dabigatran and edoxaban, which need about a week of an injectable first. And of course warfarin, which needs that classic bridge with something like LMWH for at least 5 days, and until that INR is actually in the therapeutic range. You can't skip that step. It's all about making sure the patient is protected while the warfarin slowly kicks in.
So the next big question is always, how long? And it really depends. If the clot was provoked, say by a major surgery, then 3 months is often the standard. But what if it was unprovoked, meaning it just came out of nowhere? Well, then we're often looking at indefinite therapy. And that's a huge decision, right? It becomes this ongoing balancing act between the risk of another clot and the risk of bleeding, a conversation that you'll be a part of for a long, long time.
Okay, now we get to the absolute heart of what we do, patient counseling and safety. This is where we, as pharmacists, are on the front lines, empowering our patients to use these powerful medications safely and effectively.
So, what are the absolute must-knows? The critical side effects and counseling points you have to get across. Let's really zero in on the high-yield stuff, because what you say in that consult can literally make all the difference.
Think of this as your quick-glance cheat sheet. For rivaroxaban, it's all about the food. You have to tell them, take it with your biggest meal of the day to make sure it gets absorbed properly. Dabigatran, heartburn, and upset stomach are super common. Give them a heads up so they don't just stop taking it. Apixaban's big plus is its safety profile in some patients with pretty poor kidney function. And for warfarin, warfarin. Beyond the usual, please remind them about herbals. St. John's wort, ginkgo, ginseng, they can throw an INR completely out of whack.
Now, no matter which drug they're on, these points are non-negotiable. Every single patient needs to hear this. You have to teach them the signs of major bleeding, a killer headache, black or tarry stools, crazy bruising. You have to drill into them how important adherence is to prevent another possibly fatal clot. And please, make sure they know to tell everyone, their dentist, their podiatrist, everyone, that they're on a blood thinner.
Okay, so we've got the basics down for the general population, but we all know it's never that simple, right? What about those specific patient groups where the rules well, they change?
Let's dive into VTE in two really important special populations, pregnancy and cancer. These are cases where the standard playbook gets tossed out, and you will definitely see these patients in your practice.
And this lays it out pretty clearly. For a patient who's pregnant, it's simple. Low molecular weight heparin is the only way to go. You absolutely avoid warfarin and the DOACs because of risks to the baby and just a lack of safety data. Now, for cancer-associated thrombosis, you've got a couple of great options. LMWH or apixaban are both really effective. There's a little nuance, though. If the cancer is in the GI tract, you might lean towards LMWH.
And don't forget, our job isn't just about treatment, it's also about prevention. Think about your patients going home after a major surgery, like a hip or knee replacement. They are at super high risk. We are often the final checkpoint, the last line of defense, to make sure they actually get their prophylaxis and know how to use it. We're preventing the clot from ever even happening.
So, we've covered a ton of ground here, right? From strategies to counseling points, but it all comes down to this one question. The very next time a VTE patient walks up to your counter, what is the one key thing you learned today that you're going to use to make their care better? Because your intervention, your conversation, it really, really matters. We hope this explainer gave you the tools and the confidence to make every one of those moments count.